Couple more relatively short sections to wrap this up. Next is the patient care reports. So your patient care reports you can find several different ways. Obviously we print them. They're available in the lab to get some extras. You can stop by the EMS administrative assistant desk and she may have some for you. If not, then again in your lab you're able to pick those up. You're supposed to drop these forms off periodically. So your syllabus will explain the decals should be entered within 3 days, and then your daily clinical logs, the white copies of the daily clinical logs, and these patient care reports should be dropped off within a week. So you do need to make a quick swing by Sinclair and drop these forms off periodically. You can talk to your clinical instructor on how best to get the paperwork to them in a timely fashion. And they are, as I said, the final word when we look at those pieces. But for the assessment forms, you also have this available on your course shell. So if you need to in a pinch, you can print one of these. I just as soon have you get the ones we have. They should be all 3-hole punched for you and ready to go. But when you're filling it out, put your EMS name, the date, the unit, location. Your age group is listed on here, whether it was male or female. As I said, this is how you're listing it on your sheets. So if you're in doubt, just flip a coin and pick. And while I understand that can be frustrating, don't do it in front of the patient. You can leave it blank for the moment. You can write something in over here, but when you're entering it into the computer, you need to make sure and pick one of these, otherwise it'll throw off the tracking. Their primary positioning problem, just put an X or circle it. There can only be one. When you're filling in this information, these get discussed in class, so I won't spend a long time on this, but we want you to put stuff in every single section until you have been told by your instructor that you're okay to use this as a blank narrative. I would rather you start by doing this. As a rule in the hospital, we have you doing this through the entire hospital because we end up getting people missing stuff all the time. And it's entertaining for a while to have you chase back in and say, how are the lung sounds? Oh, I don't know. Go back and listen. Oh, hi, mind if I listen to your lungs? Okay. Well, what was the pulse in the other arm? Oh, I didn't check that. Well, go back in and check it. Okay. Did you use the Dynamap or did you do a manual blood pressure? Well, with somebody with hypertension, you should do a manual blood pressure as well. Go back and do it again. They have the pulse ox on? Oh, no, they didn't have that on. So go back and get that. Said they're allergic to grapefruit. What happens when they have grapefruit? Oh, I don't know. Well, go back and get it. So we really want you to get used to using this form at least to start with, and then you can go off book later once your clinical instructor tells you you can do so. Medications, as I said, what medications you have, just the base classification and the indication. You don't have to go into grand detail of every last little bit of dose and so forth. We're not worried if somebody's taken 500 milligrams or 850 milligrams of metformin. That we're worried about, are they taking metformin, why are they taking it, and what's the basic class of what that is. For the allergies, it's not just the allergen, what they're allergic to, but what happens. So make sure you're getting that past medical and surgical history. There's not a lot of room. You're going to find some people have big, long lists of this stuff, and you can put the key aspects on here is fine, or you can kind of double up some stuff as is needed. But physical exams on here, we want to make sure that you've got information on everybody. So NKDA, no known drug allergies, is okay, but maybe there's no known drug allergies, but they're allergic to bee stings. So it wouldn't hurt to put that down on there and say, you can mark it as anaphylaxis, or you can say needed intubated, or I get an itchy rash, in which case sometimes you'll find the drugs are going to be given anyway. For the physical exam, we want you filling in each section. You're not supposed to be writing normal down for anything on here, but one of the exceptions to that is normal sinus rhythm is okay. But not applicable, nothing is not applicable. So when you get into things like the skin, so when we're looking at skin color is normal. Well, what is normal? I can look around in a classroom and I can see 25, 30 different people, and every single one of them is slightly different. Yes, most of them are pink, but some of them might be dark brown. Some of them might be jaundiced, so and different shades. Somebody might be really spray tan. If you go to the president, there's different colors and shades and things that get into play there as well. So what is the color? So describe what that is. Skin is not normal. Skin is pink, warm, and dry, potentially on there. So list what is normal, describe normal when you're filling those in. We want you to get used to that process. The treatments and vital signs, anything that you do, if you do an intervention or a treatment, should be listed on here, and then you should mark down what the response is, what's happened. If you mark it here, you don't have to mark it up here. Mike Oster and I tend to go back and forth on this a little bit. I don't mind having things marked twice. The problem is if you have conflicting information in two different sections, it makes your report invalid. It makes it look like you don't know what you're doing. If you've got the same information listed twice, then that's effective and correct. So be really careful. Write down what's your field impression. This is what you think is wrong with them. So if you think it's pneumonia, mark that. If you think it's possible or a rule out heart attack or a stroke, mark that. And then you should have some room for your preceptors review. You won't have to have every single form reviewed by your preceptors, but I can promise you at the early stages we want as many as possible reviewed. By the time you get into the end, I tend to do a lot more of the final field clinical. I want a run sheet for every ALS run that you do, and I want to see are you doing good quality run sheets on there. And then obviously the evaluation runs, when I'm there, I want a good run sheet. Likewise, if I'm watching you do an assessment in the hospital, and I'm following you around in those cases, I want to be able to see that you've documented everything. I can see what you've done there and fill in any holes if you missed it. If I didn't see the patient, I might miss something that you missed because I wasn't there to see what was going on. But make sure you fill everything in completely and talk with your clinical instructor if you have any questions. Your preceptors, time permitting, it's awesome to have them. The nurses at the hospital and then your paramedic preceptors, have them look over these sheets and see if you're missing anything on there. And you're welcome to look at what they're doing and fill that in. I encourage you deeply, do not wait until the end of the shift to enter these things. That's where people gripe and they say, well, I can do an assessment in 10 minutes. What quality assessment are you doing? For one, a 10-minute assessment isn't terrible. You can actually get the physical part of the assessment done, but then I've got to come back here and document everything. Oh, well, no, I just do that at the end of the day. After you've assessed 20 people, you remember what's going on, and then when you start to write and say, oh, you know, I never found out why they, or what happens when they have that allergic reaction, you can't go back and ask the patient. So the ideal is to fill out a sheet after every patient that you do. I don't mind if you take a notepad, you write down notes on 3 or 4 patients, and then you go back, sit down, and write out your run sheets. And if an IV comes in, by all means, go ahead, start the IV, and then come back and go back to work with your assessments and get the documentation done. But do the documentation in a timely fashion. You should pretty much never go more than 30 minutes after the assessment before you're entering the documentation or writing the documentation out. Just work with your clinical instructors and practice. Get better at each one of these. If you have questions, again, clinical instructor is your primary source.